So this is mainly done for a two patency test. Okay, one thing you had to keep in mind that this patient should not have any vaginal infection or acute pelvic inflammatory disease like that. Otherwise, we will spread this infection to peritoneum. Okay, first you had to check whether the patient is cervix and vagina is healthy. Then only you can suggest an hysterosalpingography. After doing a hysterosalpingography for 3 months, there is an increased chance of pregnancy. Okay, this is one of a clinical observation. Another test is is also done as a part of infertility evaluation. This is a diagnostic laparoscopy. Diagnostic laparoscope, as we all know, it's a fiber optic instrument. After piercing this anterior abdominal wall, using a venosal needle, carbon dioxide is inserted so that the abdomen gets insufflated. Then, with the help of a trocar, another incision is made, and the incision is made here, or this, and the incision is made, and through that incision, a light source or a telescope is passed, so that you will get a view of the inside of the abdomen. This is a laparoscopic view. You can see a normal uterus with this white. This is an ovary, and this is a fallopian tube. This is the normal view of a peritoneum. So, and the pouch of Douglas, all are clear. All the membranes. Just look for all the findings. This is mainly done to as a part of infertility evaluation, or also done as a part of treatment modality also. So this is a laparoscopic view of this is a normal endometrium. Normal image and laparoscopic image, and this is a laparoscopic image of an endometriotic pelvis. Okay, you can see the severe endometriotic deposit is there. In the ovary also you can see this endometrioma. Okay, these are two endometriomas and severe adhesions in the pouch of Douglas. This patient may definitely have dyspareunia, that is pain during sexual intercourse, or even severe pain during menstruation. This is a laparoscopic chromoperturbation, that is with the help of laparoscopy. That is the laparoscopic view. With this, another, the patient dye is injected through the cervix, and with the dye is injected, with the laparoscopic view itself, you can see the dye passes through the fallopian tube and it falls in the peritoneum. We can view that. That is the laparoscopic chromoperturbation. Like this blue dye is injected, and this dye usually absorbs within 3 to 4 hours. Sometimes the patient may, if they're doing like an HST, sometimes the patient may have mild abdominal discomfort or cramping may be seen, but usually this dye gets absorbed in 3 to 4 hours. And the investigation is hysteroscopy. Hysteroscopy, like laparoscopy, the hysteroscope, the instrument is passed inside through the cervix. Like after lithotomy position, after cuscos is inserted, then this hysteroscope is passed inside the cervical opening, and a distension media is using, like carbon dioxide or normal saline, like a distension media is inserted. Okay, after the insertion of media, you can see for whether there is any abnormality inside the uterus. Like this is a normal view. You can see the openings or the ostium where the fallopian tube is attached. There is no fibroid, no polyp, nothing like that. In this case, you can see the fibroid, etc. So, with hysteroscopy is usually done if there is a suspected case of septum. That is whether septum is present in the uterus or polyp is present in the uterus. With the hysteroscope, along with the hysteroscopy, they will do as a curate also. They will remove the septum also. So this procedure can be used as a screening method or also as a therapeutic means they can use. So endometrial biopsy or endometrial sampling. We are taking in this with the cuscus inserted, and an endometrial sample is taken. That is from either from the like a scraping is done, both from the anterior abdominal, posterior abdominal, anterior uterine surface or anterior, posterior, both lateral. from these four areas, samples are collected and they are evaluated, especially done in postmenopausal bleeding. That is, even after menopause, there is bleeding. There may be chance of this endometrial hyperplasia or endometrial CA. To evaluate that also, we can use this endometrial biopsy, or even patient with abnormal uterine bleeding, we can do this endometrial biopsy. Another common is CA125 tumor marker. Tumor markers evaluated for any ovarian tumor, or even CA125 is increased in patients with endometriosis. In endometriosis patients, the CA125 may be much increased than the normal value. So it's also marker we can use in the endometriosis and also ovarian CA. So some of the common, next is the breast tissues. Some of the common breast disease you may get in your OPD, maybe the patient may complain of a lump in the breast, or there may be pain, or there may be discharge like bloodish or yellowish discharge from the nipple, or even some redness in the. So it is always advised to do a screening test, either do a mammogram or a breast USG. Or even if cyst is there, we can also do an fine needle aspiration also. If patient is of younger age, or if the patient is a pregnant or a lactating mother, we can do a breast USG. Then by this we can see whether there is a tumor or a cyst. Cyst is a fluid-filled swelling. If a mass is present, we will assess the shape. If there is irregular shape, is always a sign of there is a possible chance of malignancy. And also the blood supply to the core of the tumor. If the more blood supply is there, then also it is a suspected malignancy. And microcalcification, there is a calcium deposition is seen in the tumor. These are some of the symptoms, or some of the observations, or some of the images that we get for if we are suspecting a malignancy. A mammogram is also a soft breast tissue imaging. It can detect, the best thing is it can detect a cancer even before a lump is felt. So it can detect even before that. It gets used either for screening purpose, like if there is a family history of breast disease. So like routinely a woman can do a routine mammogram every 2 years. Here also this margin, and if simple cyst is present, you can do a fine needle aspiration to do a cytological studies. So in moving to infertility evaluation. So in infertility evaluation, as I said, the case taking is important. We had to take case of both patients along the marital history, sexual history, the previous illness, especially if males are there, the history of moms, like that. Everything we had to do a thorough history. So if the first and foremost test we had to do in a male infertility evaluation is a semen analysis. So we had to advise a semen analysis for after 2 to 3 days of abstinence. So after 2 to 3 days of abstinence, we will get a proper sample. We will evaluate for a sample test. We will evaluate for the volume. If the volume is less than 2 ml, so that is not normal, then we can do a pH evaluation. Is there liquefaction? If liquefaction more than 30 minutes or 60 minutes is not normal, look for viscosity, total count, motility, okay, sperm agglutination is there, the progressive motility, morphology, all these factors should be looked for. So if in patients with azoospermia, some patients may complain with azoospermia, absence of sperm. Such patients, we had to do an ultrasonographic scanning, and also hormone assay like FSH, LHS, etc. Even testosterone or prolactin, depending upon the patient condition. And cervical factor, we can also assess the post cervical test, post coital test we can do to assess the anti-sperm antibody reaction between the with the mucous membrane. And also we can do assess the cervical mucus for bacteriological study. And then for a female, we can do a follicular study to assess the ovulation. The first and foremost, you had to do a semen analysis. After you take the history that the patient is having a regular cycle, her cycles is regular, then assess ovulation by doing a follicular study. Further, if ovulation are normal, further we can do a tube test to assess the tubal patency, or even the cervical factor, or even you can do examination to look whether the cervical opening is patent, like there is a pinhole cervix is there, or sometimes you had to ask whether the patient is having a regular sexual contact also. Sometimes the patient may come to you claiming that they are having this infertility issue. By if taking by case, we can see that the patient may have only they have sexual contact for once or twice in a month, but they have no, even they don't have any idea about the fertile period also. So you had to educate them also. You had to educate them also about the fertile period, etc. So here ends the gynecological evaluation. So these are some of the syllabus points that we covered. The diagnostic for PG students, the diagnostic techniques in gynecology, and the basic knowledge of pathological and biochemical investigation. For BMS students, antenatal investigation, investigations in fertility, etc. And non-detailed about laparoscopy, hysterosalpingography, etc. Thank you for your patient listening. If any doubt, please ask.
Yeah, thank you, doctors. Thank you very much.
Thank you.
So I think some questions in the chat box there.
Okay.
So what is the method of evaluating the PMNL rate? How it is done?
PNML rate,
Hmm.
can you please specify it?
Yeah, it is asked by Dr. Ujida Suresh. Doctor, are you there? Okay. I think we can go to next session.
Okay.
Next question. Uh, wha- so, what indication of laparoscopic chromoturbation?
Laparoscopic combotubation. Okay.
Yeah.
I had already discussed about that. If by laparoscopy nowadays, they are using for infertility evaluation. Like if a patient, they both the couples are having, they're normal, even though pregnancy is not happening, then a diagnostic laparoscopy is usually advised. For doing when doing this like diagnostic laparoscopy, they are also using this chromoperturbation to check the patency of the tube, so that all the factors are excluded for an infertility evaluation.
Yeah, participants can now unmute themselves and ask the questions. Okay. So, asking about the AMH and its some details.
Okay, AMH level means AMH is anti-Mullerian hormone. Actually, the woman is having an ovarian reserve at the time of her birth. At the time of the birth, woman the ovary of a baby is having, especially the girl baby, in her ovary, there will be an ovarian reserve, which is essential for the normal ovulation till her menopause. It is that miniature form is present in her ovary. It is known as ovarian reserve. So AMH is a value, AMH is a marker which we use to estimate the reserve that is present in the ovary. We don't have any other tool to evaluate the ovarian reserve. The only tool is AMH and AFC. AMH is anti-Mullerian hormone. AFC is antral follicular count. By this, we are assuming that if the AMH or AFC value is normal, we are assuming that the ovary is having adequate reserve. But if the value is low, then we assume that the ovarian reserve is less. So this is now gaining more importance because in infertility management, if AMH is less than 1, they will not do any IVF treatment. So most of the patients came to Ayurveda for to increase. They itself came to us say that I have low AMH. I need medicine to increase my AMH. Like that nowadays patients are coming. Now it is gaining more popularity. So the normal AMH value is between 2 to 4 nanogram per ml. It is combined with AFC. Antral follicular count is AFC and AMH value are both done together to make a diagnosis of diminishing ovarian reserve. Is it clear, doctor?
Thank you, ma'am. And yes, polymorphic nuclear leukocytes, that is PNML, that means.
Sorry, Dr. Ujit, I don't know about this polynuclear leukocyte. Sorry. I'll refer and I will inform. Okay.
So next question regarding differential diagnosis of breast diseases based on mammogram.
So if I had already mentioned that if there is microcalcification or if there is a tumor with irregular margin or if there is more blood supply into the center of the tumor, then there will be a chance of malignancy. Otherwise, a heart mass, which can also be benign, like a fibroadenotic disease, like that, it's more commonly seen. Okay.
Okay, and is it possible to increase the AMH value?
Like that, most of our medicines have action on the ovary. If the ovarian reserve is much low, so we are giving medicine to improve the ovarian function. If there is ovarian reserve in her ovary, definitely our medicine can stimulate the ovarian function. If there is no reserve, so even if we are giving medicine, the ovary will not respond because it doesn't have any reserve, or it may have only low reserve. If the ovary is having reserve, definitely our medicines like Sukumarakritam, Shatapushpa Churnam, Dadimadikritam, Jeevaniya Ganakashayam, all have specific action on the ovary, which increase along with AMH, the quality of the follicle is also increasing. Even if the AM in some patients, I have seen patients with zero point 0.5 nanogram, she conceived naturally. She was advised to do an IVF with donor egg. That patient with zero point 0.5 nanogram conceived naturally because our medicine increases the quality of the ovary. But some patients even with 1.9 nanogram, that is 2 is almost normal. If the patient is having 1.9 nanogram, in that patient she may not conceive, but it depends upon the patients. Okay. But our medicine definitely has role in AMH. If you want to read more about this, just Google my name along with this AMH study. Then you will get an article where I have done part of the project with 60 patients, evaluating our Ayurvedic management on the 60 patients, and the result is published. So you can just Google it and you will get it.
Okay, thank you, ma'am. I think all questions are answered. Any further question, you can unmute and ask, okay?
Hello, ma'am. Hello, ma'am. Hello.
Hello. Yes.
Hello, ma'am. There is normal delivery. In a normal delivery, the baby comes outside the uterus from the head portion. But
Mm,
in some cases, the baby comes outside from the leg portions or the
okay.
downward portion.
Mm.
Then
Breech presentation. Mm,
in that cases the chances of living are low.
Okay.
And in some cases the doctors do surgery or abortion,
Mm.
advise in some cases abortion. Then is there any possible chance of normal
No,
delivery?
no, no, no. Actually, if a patient is with head low, that is in cephalic presentation, there is a chance of normal vaginal delivery. If breech presentation, that is if the buttocks portion is in lower portion, so the normal pregnancy is not possible. So you can do a cesarean section. There is no need to do an abortion. You can do a cesarean section and take the baby lively. Okay. So this is cephalic presentation. The breech presentation is one of an indication for cesarean labor. Okay. Hello, doctor. Am I audible, Dr. Kedar?
Yes, ma'am. Thank you, ma'am.
Okay.
Hello.
Yes,
Hello,
Dr.
Dr. Divya.
Swati. Yes.
Very good evening, ma'am. Thank you so much for very
Okay.
lucid presentation. I really loved it. And you cleared all the
Thank you.
concepts. I would like to ask you, ma'am, after the menopause, how frequently do you recommend